Now we're starting Learning Plan 9, Manage Care for Patients Experiencing Eating Disorders. So we're looking at Chapter 18 in Vaccarolis, Feeding and Eating Disorders. So we're going to start with a quote from Demi Lovato. Eating disorders are serious mental illnesses, not lifestyle choices. Um, I really think that's an important concept to think about, not only with eating disorders, but of course with all mental illnesses, especially the ones that the general public can tend to think or feel are a person's choice. So certainly eating disorders would fit into that category, depression, anxiety, substance abuse disorders. So many people really feel that a person is choosing those behaviors. Of course, there's nothing further from the truth. So I did a little digging. So I know Demi Lovato is a famous person, and I'm not somebody that necessarily pays a whole lot of attention to singers or actresses. But anyways, I found an article that talks about that Demi Lovato has struggled with bulimia for years. And she still says food is the biggest challenge in her life. So the concept there to think about is that even when people are considered recovered from an eating disorder, and sometimes that can really take quite a long period of time, that there's still a chance of relapse, especially during stressful life circumstances. So it's almost hard to say that you're ever fully recovered from an eating disorder. I even know people personally that have struggled with eating disorders, and they still say, even though it's been maybe many years that they've been at a healthy weight, they will say things like they don't like hearing people tell them that they look good because their immediate interpretation is, oh, I'm heavy, I'm overweight, I've got to lose weight. So that part of the mind can still kind of kick in every now and then. And other people that I know too personally just say that it still is a very sensitive issue, the whole aspect of body image. And even when you have changes in body image, such as becoming pregnant, how sometimes things like that can just wreak havoc on your self-esteem and self-image, especially if you have that history of an eating disorder. So I kind of read a little bit about Demi, and basically she said that she suffers from bulimia. She began binge eating and purging at age 9. That is really young. Think about it, 9 years old. And she herself can relate these issues of eating disorders back to her childhood. Her grandmother and mother battled with eating disorders. Her father fought alcoholism, bipolar disorder, and schizophrenia. She was bullied by her peers at school. So not only did she have the eating disorder issue, but she also began cutting herself and self-medicating with alcohol, cocaine, and painkillers. So again, think about comorbidities and how similar that addiction, compulsion, and eating disorders really kind of all go hand in hand. So hers is a really, really good example. And she said, basically, I lived fast and I was going to die young. She said, I didn't think I would make it to 21. So really a difficult way of life. And so she did end up going to a treatment facility and slowly began to recover from her bulimia and her addictions. And it sounds like she's been sober for quite a while, according to this article anyways. But basically, recovery from eating disorders can take years, and people do have relapses, and she relapsed, sounds like, when she had a breakup with a boyfriend. Very beginning paragraph in your book, it says, of all the psychiatric disorders, eating disorders may be the most perplexing. Think about it. Eating and sharing food is usually something pleasurable. It's something that we look forward to. There's a lot of cultural importance that we attach to food. And besides that, it is certainly necessary to life. We can't live if we stop eating and drinking fluids. So it is a necessary thing, but of course we do put a lot of emphasis in different ways on different types of foods that we eat. Think about what your family does on a holiday. So food is probably the most important thing that you do for a holiday, right? Well, of course, getting together with people that you care about is certainly an important aspect of that. But gosh, everybody seems to be focused on the food. What are you going to have to eat? Who's going to bring the dessert? I mean, food is just such a big part of our daily lives. So to think about somebody purposely starving themselves or eating and then throwing up on purpose or inducing diarrhea by taking medications is just kind of something that's really hard for most of us to really fully understand. So I like this quote too. The size of our body has nothing to do with your worth, nothing. So just another very impactful type of statement, because people that have eating disorders usually do tie their self-worth and self-esteem to their body shape, size, and of course their weight. And if you have the strength and ability to sustain an eating disorder, then you have the strength and ability to move beyond it. So I do think, though, that while that sounds pretty inspiring, and I agree with part of it, because honestly, if you think about the strength that it would take to deprive yourself of food. I mean, goodness, it's certainly hard for me. If I'm hungry, I can't stand being starving. I want to eat something, and I'm sure most of us feel that way too. It really is. If you go way too long without a meal, you're really suffering. You're not feeling good. You're feeling hangry, I guess, is the best word to describe it. That's I don't know how exactly that phrase got coined, but it's really a good one. You're starving and you're emotionally not feeling very good because your body is just craving food. So, to think about that, the strength that it takes to deprive yourself really does have to be incredible. But I do think that the other flip side of the coin is somebody could read this and think, well, it's just a matter of self-will and self-control, and I can overcome this. And truly, once you have an eating disorder fully established, you really need therapy and many times medication too, especially to help with the mood and the anxiety aspect of it. So it isn't something that you can just decide one day, I'm no longer going to have an eating disorder. In other words, like making it like, oh, it was your choice and you chose to do this and now you can choose to not do it. It certainly isn't that simplistic. Of this quote, by the way, is a therapist who deals with people that have eating disorders in California. And she also does Skype interviews also, which is kind of interesting. And she has written books, kind of like more like self-help books on dealing with eating disorders. And I think that that aspect certainly could be very helpful, but you would certainly hope that that person who has a serious eating disorder will get into a regular therapy sessions, or if, certainly some people even need hospitalization if their weight gets really low and they're physically in danger, because that's the other aspect of eating disorders is physically they are very dangerous, and people do die of eating disorders, of the complications of eating disorders. So it is, it's great to read books and to have self-help kinds of things to refer to, but also we truly have to take these again very seriously. It's not just a matter of reading a book and that person's going to experience recovery. It truly is a long, hard road to recovery. Before we get into the epidemiology, I just also want to refer you to the YouTube videos that are in this learning plan. One of them is on Karen Carpenter. I hope you know who she is. Sometimes lately in class, when I talk about Karen Carpenter, everyone looks at me with a blank stare. And that's probably because she was more famous when I was growing up. And so, I remember her music very well. So Google some of her music. She really had an amazing, amazing, beautiful voice, and she was very, very popular mostly in the 70s, and I think maybe early 80s, late 60s, early 70s, whenever. But so a long time ago, way before you were born. But anyways, just There's a video about her. She actually died as a result of her eating disorder. And basically what happened to her is that she was doing okay. She was at an acceptable weight. I believe she was within like 90% of her ideal body weight, which is usually the goal that they strive for. But unfortunately, she was maintaining her weight by using Ipecac. And if you don't know what Ipecac is, I believe, I don't even know that they sell that anymore, but they might have taken it off the market. They used to tell everybody, especially I remember when I had kids, 20, more than 20 years ago, to always have a bottle of Ipecac in your medicine cabinet, just in case your child were to swallow something and you needed to induce vomiting. And also when anybody would go to the emergency room for many years, and if they overdosed on something, they were given Ipecac because it would induce vomiting. So I know that they don't do that in emergency rooms anymore, and I'm not even sure that they sell it in pharmacies anymore. I'll have to check on that. But anyways, so Karen was maintaining her weight by abusing Ipecac. So she would keep, even though her weight was healthy, because she was eating, but then she would monitor her weight very closely, and if she got a little bit over that ideal weight, then she would use Ipecac. But apparently Ipecac weakens the heart muscle. So over time, and apparently she abused it quite a bit, and so over time it weakens the heart muscle and can lead to cardiomyopathy, and that is how she ended up passing away. Oh, I believe she was in her 30s when she died. So technically she died from Ipecac poisoning, but it truly was the result of her eating disorder. She wouldn't have been using Ipecac had it not been for her eating disorder. And there's another couple of videos on the same French model, and that one you'll find very interesting too. Her name is Isabelle Carrot. So there's two videos on her. Be sure to watch those too. They're both pretty short. And the thing that's striking is that in the one video, she talks about her childhood and her upbringing. So think about Demi Lovato shared her difficult upbringing. Well, this model, Isabelle, talked about how her mother didn't want her to grow, and she was very like hovering and overprotective, and she wouldn't let her go outside because she heard that fresh air and sunshine made children grow, so she kept her inside. And then Isabelle began really restricting her food so that she wouldn't grow, and I think she talks about eating like a square of chocolate and a couple of cornflakes, and that would be all she would eat for an entire day. So those videos are well worth watching. And the other one is a video on bulimia. No, not bulimia. I couldn't find a good video on bulimia because most of them show the person throwing up, and I just didn't want to subject you to that. So if you want to look up a video on your own on bulimia, that would be wonderful, but I just really couldn't find anything that was really appropriate. There is a great video on binge eating disorder. It is very, very powerful and impactful when you hear this young man's story about his struggle with binge eating and overeating, and how he is very morbidly obese, and just the struggle. And again, the childhood upbringing has something to do with it. His mother, he didn't get the love and attention he needed from his mother. She gave him a sandwich. So now he associates comfort and love with a sandwich. So again, I really think all the videos will help just to kind of reinforce some of the points that we're making. Okay, anyways. Women have a lifetime incidence of about 0.9% for anorexia, and men a lifetime incidence of 0.24% for anorexia. So males and females can have eating disorders. They're just more common in females. So again, if I say she, I'm not leaving out males, but it's just that they are much more common in females, and especially young, older childhood to early adolescence, 20s, although truly people of any age can have an eating disorder. But the thing that's striking is that really we don't know if those statistics are even accurate, because fewer than half of people with eating disorders actually seek health care for this illness. The people that do seek health care, or sometimes it's their family that is seeking health care for them, is because usually people with anorexia get very dangerously thin, and again to the point where their life is at stake. And again, anorexia may start as early as between 7 to 12 years of age. So Demi Lovato is a good example of that, being that she started her bulimic behaviors at age 9. So that's, a little bit young. Usually we think of teenage girls or young women with bulimia, but certainly can start in childhood. I know I've had students tell me in the past that there have been times when their 6, 7, 8-year-old, 9-year-old kids would come home from school and say, Mommy, are my thighs fat? And just ask different questions like about their body image. And more than likely, they were maybe getting some teasing or bullying at school, and perhaps getting the aspect of comparing already and comparing to an ideal body image already at such a young age. So the other thing I think we do have to think about is that kids definitely learn from who they're growing up with. And so if we're constantly talking about our body image and our dissatisfaction with our body image, then that certainly rubs off on kids. So you just kind of have to wonder, where does a kid 8 years old get, Mommy, are my thighs too fat? So I think we all have to kind of think about that a little bit. How do we present ourselves and our comfort with our self-image, and how do we help our kids with that? So biologic factors, so etiology. So there is a strong genetic link, and neurobiological altered serotonin has been shown in patients that have eating disorders. Patients that have eating disorders consistently have personality traits of perfectionism, obsessive compulsiveness, and a dysphoric mood, which means a bad mood, all of which correlate with the serotonin pathways in the brain. So, and these traits begin to appear in childhood before they even have the onset of that eating disorder. The other aspect of neurobiology that's really kind of interesting is that tryptophan, that amino acid, which is essential to serotonin synthesis, is only available through diet. And a normal diet boosts serotonin in the brain and regulates our mood. So drops in dietary tryptophan may relieve symptoms of anxiety and bad mood and provide a reward for calorie restriction. But if the person continues with their malnutrition, that results in a physical dysphoria or bad mood, and it's like becomes a cycle of temporary relief followed by more dysphoria, and it just sets up like a feedback loop that reinforces the disordered eating behavior. So really kind of interesting. It sounds like there's definitely more research that needs to be done in this area, and that it says studies so far suggest that there's even a difference in the reward and executive function parts of the anorexic brain. So really kind of interesting. Psychological factors, learned behavior that has positive reinforcement, and again, possibly the family issues. I just find it really interesting that they say in the book that there really isn't there hasn't been enough research to really determine definite family characteristics that are specific to eating disorders. Just usually that therapies usually focus on just emotional communication and conflict resolution. But I really just think it's so interesting, just having worked with people with this disorder and knowing, again, some families that have people that have anorexia, it just seems like there is a strong component of perfectionism in that family and very, very high expectations. And so the person that develops the eating disorder, sometimes maybe they're the younger child and the older child is the one that's the shining star. And that older child gets all the attention. They're the valedictorian at high school. They're the star of the basketball team, and on and on. And that younger child kind of feels like they can't keep up and they can't get their parents' attention the way that older child has. And so the way to gain control in their life and to get some attention from people is to lose weight, because it looks like you are in extremely good control of yourself. You have self-discipline, you have control, you have goals. And so sometimes that becomes very rewarding. The other thing about that learned behavior that has positive reinforcement is that if somebody loses weight, usually the first thing anybody says to them is, "Oh, you look really great." So that just reinforces in the person who has an eating disorder, that just reinforces that, oh, I've got to look even better. I've got to lose even more weight. I know somebody who started with an eating disorder in high school, and that's kind of what she described, that she just stopped eating for, I forgot how long, a couple of months, and she lost 40 pounds. And of course, everyone around her was just complimenting her on how great she looked. So that really spurred her on to lose even more weight. I think Karen Carpenter is a really good example of that family issues too, because I'm not sure if it says in that particular video that I posted for you, but I did see another video that I believe is a bit longer, and she really talks about how she just wanted her especially her mother's affection. And she was the younger. Her older brother, Richard, was a musical genius, apparently, from early on. And so everything revolved around him. The family actually moved across the United States. I forgot what state they were living in, but I think it was somewhere more in the east. And they moved all the way to California for Richard so that he could have a career. And here it is that I think Karen really became the most popular and the most well-known of the Carpenters, because truly it is her beautiful voice that everybody thinks of when you think of the Carpenters. You don't think about Richard's musical instrumental abilities or his voice. You think about her. So it's kind of interesting that she never really saw herself as a person who really was a very talented person herself. It was all about her brother. She never felt like she measured up to her brother's standards, and she never felt like she could get the affection of her parents the way that her brother Richard had. So I guess I do see a lot of family dynamic issues, and I do think if they truly are saying in the book that it's a problem, but they're thinking it's a problem, but there's not enough research, well, then they just really ought to do some more research, because it definitely seems that it is a trend. So environmental factors, that includes cultural influences and how we develop our self-concept, what aspects of the environment and of the community, not just our family, but kind of the media, the television, movies, books, magazines, what types of images are portrayed to us, and culturally too. So in Western culture, the ideal that equates feminine beauty is tall and thin. And usually most models are tall and thin. And the next picture I have is a picture of a model that I grew up with. So Twiggy was a 1960s model. I believe she was from England, but she was very popular in the United States. And as you can see, she was really very, very thin. So when Twiggy came out as a model, I definitely remember thinking, this is the ideal. Everybody is supposed to look like Twiggy. And of course, that's not accurate at all. So, but when society puts that out to you that this is it, this is the ideal standard of beauty, then everybody tends to measure themselves against that ideal. I do think it's interesting now that we seem to have more what they're calling plus-sized models, although I read that it's kind of interesting that a model who is a size 8 or larger is considered a plus-sized model. I thought that was a little bit outrageous, but anyways, but it seems like I think it's a great trend that they are having more models that actually look like people rather than Twiggy, because not very many people are going to look like Twiggy. And honestly, in looking at that other picture of her, she doesn't really look all that healthy. She looks like she may have had an eating disorder. That I don't know for sure. But anyways, so again, culturally, we have to think about in different cultures, being a little bit overweight might be more acceptable and might be actually even deemed not just acceptable, but more actually desirable. So we do have to think about all the different aspects of the world and our life in general that makes us kind of either feel good about ourselves or maybe even feel negatively about ourselves. And according to your book, it's basically saying that there isn't really any I guess you could say, a direct relationship between social ideals and the development of an eating disorder. But it's, again, I think it would be interesting to have more research on that topic. So, what other activities and occupations are associated with eating abnormalities? So, I'm not going to say eating disorders because not necessarily everybody in these categories are developing an actual disorder. However, some of these activities actually promote eating abnormalities. So think about sports such as wrestling. I've had students tell me that they have brothers wrestling and that they have to be a certain weight in order to compete. And sometimes, if their weight is a little bit over, these kids may end up starving themselves, maybe even if it's for a couple of days. That still isn't a healthy eating behavior. So they may starve themselves to make sure they get themselves back to the weight they need to, or they may be binging because they need to perhaps to weigh a little bit more. So they definitely are keeping very close tabs on their weight and possibly just not having good overall eating habits because they have to weigh a certain weight. Ballet dancers typically are very, very thin. Modeling, again. The movie industry, sometimes I have read articles where people have had to gain a lot of weight in order to play a certain part too. Some actors had to gain like 30, 40 pounds in order to play a certain part. And then, then after the movie's over, then you're stuck with trying to lose that all, and then perhaps even having to try to lose it quickly so that you can get another part, or perhaps weight loss. Another actress, Judy Garland, who played in The Wizard of Oz, was told also at a young age that she was too heavy, that she and the studio that she worked for constantly was demanding that she diet and lose weight, even though she was at an actually pretty healthy weight. So it's definitely the TV movie industry can really make it very difficult for people to maintain a normal weight. Professional eaters and eating contests, just think about that as an eating abnormality. Now, some of the people that engage in these eating contests and are called professional eaters aren't even necessarily overweight, but you have to imagine they're certainly wreaking havoc on their digestive system by eating enormous amounts of food. And then I believe there are cases where I have heard where they have to go into the emergency room and get their stomach pumped after a binge like that. So, it's just certainly not a healthy behavior, but There are people that really enjoy watching those eating contests. Are there any others that you can think of? So any other activities or occupations? Swimming, I guess, maybe too. I'm not sure if that one is as strict as a sport like wrestling, because I know that you have to be weighed in order to wrestle, and in order to compete, you have to be at an appropriate weight. So it is just kind of interesting to think about different aspects of our life that possibly can promote abnormalities with our eating behaviors. So comorbidities. So 56% of those with anorexia nervosa have a comorbidity. 94% of those with bulimia have comorbidities, and 79% of those with binge eating disorder have comorbidities. Usually the most common are mood and anxiety disorders, personality disorders. Those are the most common co-occurring disorders. And many physical comorbidities develop as the disease progresses. So people that have bulimia have a lot of different physical complications, and we'll get into those when we discuss each of these individual eating disorders, but huge amounts of comorbidities with these disorders. So now with anorexia nervosa, so the assessment is that we really want to understand what is the person's perception of the problem. Or I guess a better way to put it is, do they feel that they have a problem? Do they perceive any difficulty going on right now? Because many times the denial and the distortion of their body image really prevents them from seeing what's going on with their body realistically. They will be very, very thin, very underweight, and still feel that they're fat and they need to lose weight. That body image distortion actually truly takes on a psychotic proportion. I want to know what their eating habits are. What do they eat and how often? And again, that's a difficult question, because there are times when they really may not be very honest and tell you exactly what they're eating, because it's such a small amount. So again, the square of chocolate and 3 cornflakes, whatever, that might be all that a person is consuming in a day. So they may or may not tell you that, but that certainly would be a very important thing to try to get at. And I think, again, being just very non-judgmental and just trying to be factual and as helpful as you can in order to get that therapeutic relationship. So hopefully that person will tell you what exactly their eating habits consist of. We want to know their history of dieting. How long has it been since they've been dieting? Do they diet continuously? Do they diet intermittently? What types of methods do they use to achieve their weight control? Now, something that we haven't said yet, but between anorexia and nervosa, sometimes those two disorders can exist at the same time in the same person. So even though there's definitely characteristics that are specific to anorexia, characteristics that are specific to bulimia, sometimes people have a combination of both of those disorders. So it is important to ask about methods used to achieve weight control, because sometimes people with anorexia also can purge. So they may have periods where they binge and then they purge. They may be using laxatives. They may be self-induced vomiting, taking diuretics, diet pills, all kinds of things. So it's really important to find out what exactly they're doing to achieve that weight control. Are they exercising to the point of being, very excessive? And the value they attach to a specific shape and weight. So many times, unfortunately, when somebody has anorexia, their whole self-esteem is tied up in the number on the scale, just completely 100%, and they get very, very upset if that number goes up, especially when they're in the hospital and they are on a program where they're trying to help them to gain weight, they can become extremely upset to the point of being hysterical in a panic state when they see the number on the scale, because their entire self-esteem is tied up in that number. So that is something really important that we have to assess when we're talking to these patients. We want to think about their interpersonal and social functioning. Do they have friends? Do they relate to their family? What kind of relationship do they have with their significant others in their life? Do they have any friends? Do they do anything socially? So sometimes when people have these disorders, it's really difficult for them to socialize and even to be part of a family, because they do not want to eat in front of anyone. If there's a party, they're not going to be eating. They may make food for it, but they're going to stand back and watch everybody else eat. They're not going to eat themselves. So it's really difficult for them. If they do eat, when they eat in secret. They don't eat in front of other people. So that can certainly hamper your ability to be social, because how much of our lives do we spend eating with other people? We also want to just look overall at their mental status, and then of course physiological parameters. So we have to think about their not only their weight, their blood pressure, their blood sugar, every aspect of their physical being, because again, eating disorders are actually quite deadly. And we really have to work very hard with people in order to treat these illnesses. Of course, along with that mental status aspect, we have to think about depression and anxiety, and then also some characteristics of personality disorders that might be evident. I just want to point out too that there are two purple tables that would be very helpful to look at on page 336. Possible signs and symptoms of anorexia nervosa, the table is in purple. And then on page 337, medical complications of anorexia nervosa and bulimia nervosa. So again, very important to think about not only the psychological, but also the physical aspects. So self-assessment. I've talked about self-assessment pretty much in every single learning plan, right? You're probably sick of hearing me say this. But again, if we view the self-destructive behaviors of weight restriction, binging, purging as choice, it should really say food restriction, binging, purging as choices, that causes the health professional to put blame on the patient for their consequent health problems. So not anything that would help to help us develop a therapeutic relationship, which is extremely important in working with people with this disorder. And also we have to think about the fact that the common personality traits of perfectionism, obsessive thoughts and actions relating to food, intense feelings of shame, people-pleasing, and the need to have control over their therapy definitely can pose challenges. So sometimes patients with these disorders can be a little bit difficult for the healthcare professional to work with. So we just, again, instead of taking it personally and somehow thinking you're a failure or they're a failure because they're not responding to you, it's really good to just step back, separate yourself, and try to view their thoughts, behaviors, and feelings as this is part of an illness, and not to blame them, and certainly not to blame yourself either. So it really is a very difficult thing sometimes to build that therapeutic relationship and to work with patients that have these disorders therapeutically. So some of the behavioral assessments that you're going to see in anorexia, people have an absolute terror of weight gain, and again can experience up to panic level of anxiety with weight gain. So with weight gain that usually happens in the hospital, because if they're in the hospital, they are being prescribed meals or possibly supplements, and they are on a program to try to gain weight very slowly. But still that presents a lot of terror for them. It is a threat to their self-esteem and their self-concept. Again, if they tie their whole self-concept to that number on the scale, and now that number is moving up, they can really start to feel really badly about themselves. Many times they have a preoccupation with thoughts of food. They will read recipe books, look up recipes in magazines, look at pictures of food. They do view themselves as fat even when they're emaciated. They have a peculiar handling of food sometimes, cutting food into small bits, pushing it around the plate. And I've seen videos where some people have demonstrated how this kind of helps them to, if they're eating with if they happen to be in a situation eating with other people, which many times they avoid, then that can make it look like they're eating when they actually aren't eating. I know that sounds a bit strange, but I did see a video. If I can find it, I'll post it. A video where a young woman is showing her boyfriend how she tricks her family. So she's talking and pointing and waving her fork and her knife around and cutting up food, pushing it around her plate, and then almost putting it up to her mouth and then not, and then putting it back down. But if you weren't really paying too close attention to her, you'd think she was eating. And then she says, then she puts her napkin on top of her food and kind of says, I'm full now, when she literally hasn't put a bite of food in her mouth. And that's kind of how she said she would trick her family. So pushing food around the plate again, possible rigorous exercise regimens. So again, that would be part of like an undoing mechanism. So think about those defense mechanisms, and that would also be almost part of purging. It's not exactly purging like vomiting or use of diuretics or cathartics would be, but it's a way to kind of undo the calories that they do consume. So that is also something that people with anorexia can do. So not everybody does that. Possible self-induced vomiting, use of laxatives and diuretics. So again, some crossover with symptoms of bulimia. And definitely that cognitive disturbance of judging their self-worth by their weight. So I just found this slide randomly on the internet, just again to kind of just recap. So usually when people have anorexia, they are severely underweight. They have a dramatic weight loss. They wear sometimes loose, bulky clothes to kind of hide their weight loss because they know that people are going to comment on that. They have a preoccupation with food, dieting, counting calories. Sometimes they refuse to eat certain foods, such as carbs or fats. They avoid meal times or eating in front of others, prepare elaborate meals for others, but refuse to eat them. Exercise excessively, make comments about being fat. They many times stop menstruating, or if they are a young enough adolescent and they haven't started their period yet, they won't start. Complain about constipation or stomach pain and deny that extreme thinness is a problem. So these are all really serious symptoms that we have to think about. Now, this is a picture of the cognitive distortion that people experience. So she is very, very thin and looks in the mirror and sees a much heavier person. So that is absolutely very difficult to understand, but that is one of the hallmark classic signs of somebody that has anorexia. And it really struck home to me when I was working with a patient once who was, she was pretty tall, I'd say, well, taller than me. She was probably about 5'8" or 5'9", and I think she was like somewhere 70-ish pounds, very, very skeletal thin. And she looked at me, a normal weight, just an average weight person, and I was her nurse one day, and she looked at me and said, I really wish I could look like you. Are you a size 0? And I kind of had to put on my psych nurse face, and because I was just shocked that she, who was so extremely thin and skeletal, and I certainly wasn't like that, felt that I was the thin one and that she would like to look like me. She'd like to be as thin as I was, and she thought I were a size 0. Wow, that just really, I'll never forget that. It just was so powerful of an example of the cognitive distortion that people do experience. So now we have to think about those physical assessments, which are extremely important because, again, people do die from anorexia nervosa. So that low weight, usually we look at being below 75% of their ideal body weight. So at that point, they really need medical stabilization. So then we have the amenorrhea. So again, if they've had their period start already, their period is going to stop with all that weight loss. Or if they are young enough that they haven't started their period yet, it's just not going to start. Sometimes their skin can take on a yellowish cast. They can develop lanugo, which is fine downy hair that usually we see in babies. We're going to have cold extremities, peripheral edema, muscle weakening, constipation, especially if people are using cathartics for weight loss. They sometimes get to the point where they absolutely can't even have a normal bowel movement without using something. So constipation is very, very common. Their bowels really get used to medication and they almost can't move without it. So constipation, it can be a huge problem. And then think about if they're starving themselves and really totally restricting their food intake, there just isn't enough in, they're not taking in enough to actually form a normal bowel movement. Hypokalemia, anemia, abnormal lab values, EEG changes, abnormal CAT scans, hypotension, bradycardia, heart failure, impaired renal function, and decreased bone density. So really a lot of, again, think about comorbidities. So these are some of the comorbidities that we were talking about in the other slide that develop as the disease progresses. So diagnosis, outcomes, and planning. So many different nursing diagnoses would apply to somebody with anorexia. Certainly imbalanced nutrition, less than body requirements would be one of the number one diagnoses. So again, when we're thinking about anorexia, we're probably thinking about some of the medical diagnoses actually are going to take a higher priority than the psychosocial ones. And that might be kind of hard to think about. We're talking about mental illnesses, and usually we're thinking of the psychosocial diagnoses as being a higher priority. But honestly, with eating disorders, many times we really do have to put those medical concerns very much in the forefront. So imbalanced nutrition, decreased cardiac output, risk for injury from electrolyte imbalance. We also can have risk for injury from suicide, because sometimes people that have eating disorders become very distraught and suicidal because they just feel like they're losing control. They're unhappy with maybe being in the hospital and having to gain weight. It's a very distressing, difficult time for them. So that risk for injury would also apply, but certainly risk for injury from fluid and electrolyte imbalance is very important. Risk for imbalanced fluid volume, disturbed body image, ineffective coping, chronic low self-esteem, and powerlessness. So all of these diagnoses would be very applicable. And when we're thinking about goals, we always have to make sure the goals are related back to the diagnosis, and then we can start our planning. So medical stabilization, of course, is going to be a very high priority. And one thing that we want to make sure we work on is to avoid refeeding syndrome. So that is something that as nurses, we should constantly be looking for. Discussed on page 338 under the paragraph labeled planning, and basically it's a potentially lethal treatment complication that can result in fluid balance abnormalities, abnormal glucose metabolism, hypophosphatemia, hypomagnesemia, and hypokalemia. And thiamine deficiency can also occur. So reintroducing the nutrients must proceed really slowly to avoid this syndrome. So if somebody has been engaged in self-starvation for a long period of time, their body weight, they're more than 75% below their ideal body weight, we can't just flood them with food and nutrients all at the same time, all of a sudden. So it really has to be done very, very slowly in order to reduce the incidence of refeeding syndrome. So and again, evaluation is also a very important part of that nursing process. Physical and emotional status, not just their weight goal. So physical status, of course, we're evaluating that their vital signs are coming back to normal, that their weight is, usually the weight gain is about a pound or 2 a week, usually not more than 3 pounds a week, because again, the risk for that refeeding syndrome, we certainly wouldn't want somebody to gain 5 to 10 pounds in a week. And also that would just be very difficult for them to to accept psychologically. So we have to be very, very careful about that. So we can't just look at the number on the scale. Again, we really have to look at how are they doing physically overall, and what is their emotional status. When patients do start to gain weight, it can be a very, very stressful time for them. So many times, different types of therapy that are happening on the unit, especially if they should be on a specialty eating disorders unit, because that can help with the physical and the emotional aspect of it. So as people start to gain weight, they can experience more anxiety, a little bit more depression, and just they're afraid, they're very anxious because they're feeling that powerlessness, that feeling of being out of control. So therapy, and many times group therapy, can be very, very helpful in helping these patients to deal with their feelings as they start to gain weight. So I'm going to end this recording and start up again on slide number 20 in a little while.